Good afternoon. I'm Carolee Lee, founder and CEO of WHAM, Women's Health Access Matters, a not-for-profit focused on accelerating women's health research and investment. And on behalf of WHAM and our partners for this roundtable, GoTo for Lung Cancer and Northwell Health's Katz Institute for Women's Health, thank you so much for joining us today for what promises to be a fascinating discussion with a focus on cancer in women and through a lens of lung cancer, since it is the #1 killer of women today, more than breast, ovarian, and cervical cancers combined. June 2023 will mark the 30th anniversary of the NIH Revitalization Act of 1993, which established guidelines for the inclusion of women and minorities, all NIH-funded clinical trials and research. At that time, it took a committed bipartisan group of legislators who collaborated with many different constituents, including patients, providers, advocates, and policymakers, to develop and approve this momentous event. But we still have a long way to go. And WHAM is determined to build a new dialogue and platform to shift these imbalances, which still exist. Even though progress has been made, accelerating women's health research and investment is an economic imperative that offers tremendous returns for very small investments to the well-being of our society. Joining me today are exceptional leaders in their fields. Dr. Yolanda Colson, MD, PhD, Chief of the Division of Thoracic Surgery at Mass General Hospital and Professor of Surgery at Harvard Medical School. Dr. Claudia Henschke, MD, PhD, and Professor of Radiology and Head Lung and Cardiac Screening at Mount Sinai Medical Center. And Dr. Nicole LeBoeuf, MD, MPH, Chief Division of Oncodermatology at Brigham and Women's Hospital and Vice Chair of Dermatology at Dana-Farber Institute. I am so grateful that all of you could join us today. And let me start by introducing Dr. Claudia Henschke. And Claudia, you are a real champion of women's health and a true pioneer and a leading expert in the field of diagnostic radiology. And as the principal investigator of the largest multi-center screening program in the world called ILCAP, that already has accrued over 80,000 participants with new sites continuing to enroll across the country and around the globe, you are at the forefront of both early detection, innovation, and clinical care, which has helped to set probably a standard in screening that's been adopted nationally and globally, and for which we are very grateful. I wonder if you could share with us some of your work and its impact, particularly on women's health.
Well, thank you for the opportunity and thank you for your work. That's really a very important part. So when we started thinking about screening in the early 1990s, there was no screening for lung cancer because the chest X-ray was deemed not useful. And that's particularly concerning because lung cancer would really be an ideal cancer. If we find it early, we can cure it. And we knew that already at that time. So we thought CT scans would be the much better. And we organized a study to do that. And it stimulated other studies to be done. And now it is confirmed and it's reimbursed that you can have low-dose CT screening for lung cancer. And it's reimbursed for people who are 50 and older, who have smoked 30-pack years or more, 20-pack years or more, and who quit, who have not quit more than 15 years. We would like to really change those guidelines because we found that women are much more likely to be diagnosed with lung cancer, in fact, twice as likely to be diagnosed with lung cancer, but they also have a better chance of being cured. So they're ideal group to be screened. But unfortunately, only 10% of people who are eligible for the screening are being screened today. So we really need to make considerable outreach to get those people screened for lung cancer, and particularly women. That word has to go out, and we need to all work together on that. We find lots of other things with a CT scan of the lung. A CT scan is a simple procedure. You have to hold your breath and the scan is obtained in a single breath hold. No contrast is injected. You get on the table of the CT scanner, you hold your breath, and you get off. So it's a very quick and easy test to be done. And we look at all of the chest. We look at all the things that you see: the thyroid, the breast, the lungs, the heart, and the upper abdomen, the kidneys, the pancreas. So it really provides a health check of all of those organs. And that's what we've promoted, that we really look at all of these findings. We make recommendations for what should be, what's abnormal, what should have further workup. So I can give you several examples. For example, we see dense breasts if the breasts are dense on the CT scan, and it's a very reliable finding. And then we can make recommendations for women when they go for their mammogram to get additional tests like ultrasounds or MRIs. We look at coronary artery calcifications, and we've made a scale that's equivalent to that's been accepted by cardiologists. And we say when women have coronary artery calcification and therefore are at higher risk of cardiovascular disease. So there are lots of things. We really consider it a health check, that it's once a year you come in for a health check, and that message really has to get out. And we appreciate your help in getting that message out.
But if I understand what you said correctly, if only 10% are accessing this wonderful test, and it sounds like I have to have been a smoker to be approved to have this test. So I can't just say to you, I'd like to do this.
No, you actually have to find a physician that confirms that you have had the right smoking history and so on, and then get the scan. But we really think that when you think about the number of deaths from lung cancer, there are about 40,000 in never smokers, and 2/3 of those people are women. So we really think that the guidelines need to be expanded and focused on women in particular, because there are many never smoking women whose lives we could save.
So why wouldn't this just be part of my annual testing, like a mammogram?
Well, that's what we think. And we think the guidelines need to be expanded from the 50 and 20 pack years. It should be expanded to include never smokers, and the recognition that women, that if you screen a man at age 50, women should be screened starting at a younger age as well.
All right, well, we'll talk further about that at some point, because that makes absolutely no sense. I know one of the data points that WHAM had come across was that non-smoking white women were twice as likely to have lung cancer as non-smoking white men. And this is, again, we seem to collect data points for which no one knows why. So no one can explain why any of these things happen. But I think the fact that this sounds like it should be a non-invasive tests like a mammogram for being able to have early detection of lung cancer sounds like a great idea, especially considering that it's the #1 killer of lung cancer. How have women helped provide this important data for your research? Because you've made a few points that women seem to be treated more rapidly and successfully than men. What else has been shown in terms of the differences between male and female?
Well, for example, thyroid disease is more frequent in women. Breast cancer you can pick up on this low-dose CT scan. Coronary artery calcifications or cardiovascular disease has been underappreciated among women. So women stepping up for these screening tests is really very important. And they need to be encouraged, because then the treatment of these diseases is very good these days. If you can find lung cancer early, you can really treat it very successfully, and with minimally invasive techniques, which I think Dr. Colson will discuss in more detail.
And so where is your research headed then for early detection? Obviously, I know we now agree that this should be a standard of care. But tell me where your research is headed in terms of early detection.
So once we showed that lung cancer screening was effective, we've always had a study, an open study for women who are never smokers, for men and women, never smokers, age 40 and older. So that's been an important part of our research. And we've shown that really we can save lives with those enrolling women 40 and older, whether they've smoked or not. That really also with the family history, if you have a family history of lung cancer, it's very important to think about screening. So our research continues to look at the ways, all of the things that we can find on that single CT scan. We want to promote changing the guidelines for women. We want to integrate all of the findings so that women really start thinking of this, and physicians who are recommending it think of it as a health check for women, not just a screening for lung cancer, but it's a general health check. And then the exciting part is that much of the efforts have been, it takes a lot of effort to read the CT scans and to have radiologists focus on all the findings. So we're developing new AI techniques, which we can discuss later in the roundtable, for reading these CT scans and making the whole process more efficient.
Yeah, that's become quite the fascinating topic, and I look forward to talking about that in a little bit. Well, thank you so much, Claudia, for sharing all this work that you're doing, which is extraordinary. And of course, this should be just one part of my normal screening, but we'll see what we can do about that. But the importance, obviously, of early diagnosis that you're focused on is tremendous and very encouraging. So I'd now like to turn to our next panelist, whose research focuses on the treatments for women in cancer, Dr. Nicole DeBoeuf. And Nicole is the chief of the Division of Oncodermatology at Brigham and Women's and vice chair of dermatology at Dana-Farber. I'm not going to go through all of her incredible accolades and degrees, but I had the pleasure of meeting Nicole several years ago. We were just saying we don't know where 3 years of WHAM starting have flown to, but it was great to meet you then and wonderful to include you now. So Nicole, what struck me when you spoke then and even now is that skin cancer is the most common cancer in the US, but more common in women, which we find there are many diseases that are more prevalent or appear differently in women. So can you share with us a little bit the sex differences you see in how skin cancer is presented in women and the treatments for different kinds of skin cancers?
Sure. Thank you again so much for having me and for all your work in the space. We really, really appreciate it. And again, yes, 3 years have flown by, and I'm happy to share what we've done, but also sad that what we've done feels like a drop in the bucket yet again. So there's a long way to go in terms of progress. And you alluded to the two hats that I wear here at my institutions, one in taking care of patients with both common, advanced, and rare skin cancers, and the other is in managing the side effects of cancer treatment with a particular focus on the skin. So to answer your first question about skin cancers, when we think about our common skin cancers, we're usually talking about cancers like melanoma or squamous cell skin cancer. And what we see is that women are more likely to develop these cancers, under the age of 60. But then as they get older, men actually have a rapid increase in the frequency of diagnosis of these cancers. So something definitively happens with that random arbitrary age point that has been applied to the studies. And what we also see, which is a little bit different, I think, than the lung cancer world, is that men are more likely to die of these cancers than women across each of the different cancer subtypes. So melanoma, squamous cell, Merkel cell. And so we know a little bit about the different immunology that happens at the level of our cancer-fighting T cells inside the body. But our answers to the why questions remain challenging. So it's great that women are less likely to die. But we still need to learn from them why that's the case, because I think if we study the why in the skin cancer world, we could potentially apply it to the cancers where it's not the case. And so really looking at the sex differences in the groups is, I think, really important. When we think about treating cancers in melanoma, what we see is that if you have for example, a particular mutation in your melanoma called a BRAF mutation, it's sort of a signal that you can respond to a targeted therapy that hits that gene mutation in your melanoma. And females or women are actually more likely to respond to targeted therapy than men when each carries that mutation. When you look at immunotherapy, so one of the newer classes of anti-cancer therapy that's evolved over the last 15 years and has really changed the entire landscape of cancer care is actually leveraging the body's own immune system to fight cancer. And when you give melanoma patients immunotherapy, there's sort of a little bit of conflicting data out there about how much the difference is, but women tend to do better when it comes to response to immunotherapy as well. So both women do well, and they have better overall survival when they get immunotherapy, but the degree to which that matters appears to be sex dependent. And again, we know very little in terms of the why. So there's a lot of important observations happening when we diagnose and we treat these common cancers, and there's a lot of questions that remain. I think I wanted to share with you, because I think you'd appreciate it, the even rarer skin cancers that we see. There's one in particular that's very near and dear to my heart called extramammary Paget's disease. And it sort of connects to Paget's disease of the breast, but it's a very, very rare skin cancer that primarily affects the genitals. And we know so little about it. So the vulva in women and the penis and scrotum in men. And I now seem to be running a EMPD clinic over here because people come from all over, mostly because my team has we're working hard to save the genitals, and my medical students made that mug, and that came from the observation of seeing women with vulvar extramammary Paget's disease coming in with these radical surgeries, removing the entirety of their labia, their clitoris, the entirety of their female genitalia, and I started recognizing that. What the heck is going on? All the women are getting their entire genitalia removed, and it's very rare for a man to get a penectomy. And they actually call it an emasculation surgery if the man gets all of his genitalia removed. But for women, it's a simple or a radical vulvectomy. So there was just like this really obvious difference in what we were observing. So we've done a bit of work now looking at our entire cohort over the last 20 years at Dana-Farber and Brigham. And it turns out, just on our first look, and we're cleaning the data right now, it's something like 79% of women with vulvar EMPD undergo vulvectomy, whereas only 20% of men with penile EMPD undergo penectomy. So there, even with our common cancers and our rare skin cancers, there are such dramatic, there are subtle and then dramatic sex differences in how we view them and how we approach patients with these cancers. So I think, we have a long way to go when it comes to really being equitable in how we think about it and really diving into the why. So yeah, why the heck does EMPD occur more commonly in women? No idea. But then who decided it was a good idea to do these surgeries, and how am I going to stop them? Stopping them with research and trying to publish as quickly as possible. But the presentation and the management of skin cancer and all cancers, I think there are so many questions to be answered, and how they impact women specifically.
Well, we could spend days now answering that, but I think I'll ask my next question
Sure.
judiciously. So your research focuses on understanding the immunologic mechanisms or side effects to cancer therapeutics and to implementing therapies or other interventions to mitigate them. So where are we today, in your opinion, versus, where we were focused on, as I said, 1993, 30 years ago, what happened, and understanding the effects of these side effects of women, and where do we need to be heading? So I realize we've come a long way. In some ways, we haven't, like you just pointed out. In others, we're not going to be able to fix everything, but I'm kind of curious to see, in your opinion, have we moved from, we've done a lot of movement from 30 years ago, but kind of where do we need to be moving towards, in your opinion?
Yeah, sure. So I think we have made progress. So we've known for several decades that women have stronger immunologic responses, that we're more likely to get autoimmune disease, that we're less likely to get cancer. And we've moved the needle in terms of understanding a little bit about the higher estrogen state and how that changes the type of cells that you have circulating in your body over the course of your lifetime in response to hormones. We have done nothing to modulate that, or to say, hey, we see this and we observe it. Should we be doing something with hormones to alter treatment? Again, 30 years ago, we didn't have targeted therapy or immunotherapy. And so even looking at the way that these side effects present differently in women and men from traditional, cytotoxic or traditional chemotherapies, and then the other two major categories, targeted and immunotherapy, we had no information and no one was looking 30 years ago. And what we know now is that across all three groups, that women are at substantially higher rates of developing severe and symptomatic adverse events in all three categories. So women getting traditional chemotherapy are about 35 or 36% more likely than men to have a severe symptomatic side effect. For targeted therapies, it's about 25% higher. And for immunotherapy, it's about 67% higher. So women are much more likely to have severe symptomatic side effects from these drugs. Again, it goes along with potentially having a better response to these drugs. So these are the people where we know they're going to have more side effects, and we need to think about how we can keep them on these drugs that we know are going to work best in them, because the female immune system seems to be best at responding to these treatments. So we've made a lot of progress in sort of the observation. We've made some progress in the basic science, and we've made some progress in the treatment realm as well. So scalp cooling. 10 years ago, when I talked about scalp cooling to prevent chemotherapy-induced alopecia to our breast team, I was laughed off the stage, essentially, like reminded it's just hair and things like that. But, we know that 8% of women with breast cancer will decline chemotherapy because they don't want to lose their hair. And people scoff at that and say it's vanity, but it may actually be a 40-year-old who doesn't want to lose her hair because her children will then know she has cancer. So there's complicated things that go with that. And scalp cooling can dramatically reduce the rates of hair loss in certain regimens by, 80% of people who use it with taxane therapy don't need a wig. And so we have extremely big strides in terms of increasing access to things like scalp cooling, to increasing insurance coverage. It's not covered by insurance. It costs $2,400 out of pocket. So there's a huge disparity in people's ability to access something as simple as the DignaCap or the Paxman cooling cap system. So I think we've, again, scratched the surface in making the observations, but we really, really need to invest in understanding the basic science behind what's driving these differences, and think about really creative ways of how we can modulate them, and then look at the data that we have on interventions like cooling the hands to prevent taxane toxicity, topical therapies to prevent target. There's so many things where we have some data to support it, and the trials just need to be, we need to rev them up, fund them, get them enrolling quickly, and get the data out there, because we're here. We can do it, but we need teams of people to do that, and that needs institutional and financial support to make that happen.
Gosh, well, thank you, Nicole, for the groundbreaking work that you're doing to investigate these sex-based differences in skin cancer, and certainly to the mitigation and the mitigating side effects for all, and especially for women, as we've pointed out, who are often disproportionately, differentially affected or exclusively affected by these different situations. So thank you just for everything you're doing. And I'd now like to introduce an incredible physician, Dr. Yolanda Colson, who's the chief of the Division of Thoracic Surgery at Mass General and professor of surgery at Harvard Medical School. And she's also the 103rd president of the American Association for Thoracic Surgery, becoming the first female president of the association, which I'd like to point out is a major step in the right direction that might bring a female perspective. And thank you, Yolanda, for joining us. So in addition to having an MD from Mayo Medical School and a PhD from the University of Pittsburgh, you also have a degree in biomedical engineering, and I suspect that that has something to do with how your work has been guided in preventing cancer reoccurrence and your investigation into novel methods to identify hidden tumors. I wonder if you could share some of that with us.
So I would love to, and I want to thank you so much for kind of putting us together. It's been a great discussion so far, and I look forward to our roundtable. And I also really look forward to, from a surgeon perspective, to really say what an exciting time we are now in the last year or two. And I think without having lived it, because I've been seeing patients for 20 years now, I know it sounds like I'm really old, but in seeing what I used to see, or how patients came to me, or what I had to do in order to treat them, it's so different in the enthusiasm, like we were just at our meeting, the enthusiasm that there is among the thoracic surgeons and the thoracic oncologists, and our ability to really start curing people is palpable. It's actually really a fun time for us because it's been hard until now. And there's a couple advances that I think are really important. And much of it has been driven by the great work that Claudia did in getting these trials started, because our number one thing is to find things early. And one of the things I just want to add is that when we get a CT scan, most of the lung nodules that we see aren't cancers, so that people watching this don't think that if they have a nodule reported on a chest CT, I don't want them to all think they're going to have lung cancer and die. The majority are not cancers, but finding them early is critically important because those are the ones that we could cure. And most of those cures are done with surgery, which is why the surgeons are all excited, because we're now finding things so much earlier than when we used to find them because somebody had symptoms. And now most of these are found incidentally. It's starting to shift our whole curves and who we see. The number of patients we see with early stage lung cancer used to be very small, and it's now driving up that we see in more and more of them. Clearly, with only 5 to 10% of patients getting those lung cancer screenings, if we were to actually get that to those that were eligible to get it, it would dramatically shift it. And I totally agree that we need to find out new ways to include people who currently don't qualify, that being women, and I'm sure we'll talk about that in the roundtable. We know, though, that when we do surgery to remove the tumors, and there's a variety of ways of doing that, that some of them will recur. Even though we've taken all the tumor we can see, we don't think it's anywhere else, and some of those will recur. So the work that we've done through our research is looking at ways of preventing them from occurring. And tumors tend to recur in one of three areas. They recur locally, very near the site where the tumor was. They recur regionally, maybe the lymph nodes that drain where the tumor was, or they can recur more distally, either brain metastases or bone or somewhere else in the body. And we now are coming up with really interesting ways of approaching each of those ways. And so some of the work that we've worked on is actually looking at ways of delivering drug locally in order to try to prevent recurrence right at the site. There's new work coming out that's very exciting, that's just been in the last couple months, that we may be able to take less lung with the tumors, because we're finding them sooner, and we're finding out that we maybe don't have to take out 25% of the lung, right? We might be able to start taking out smaller sections of the lung, therefore making it better for that people can save some of their lung function. Looking at lymph nodes, some of the work we've looked at is actually looking at little nanoparticles that if we put around tumors, they can migrate and deliver chemotherapy in the lymph nodes, but not systemically, so people don't have the side effects of that. And then there's some very interesting new regimens, much like Nicole talked about, with some of these immunotherapies and some of the targeted agents that are particularly effective in women, that are completely changing the rate of recurrence rate. So one of the newer trials that came out is the Adura trial, where in patients who have a specific mutation that women have a much higher risk of having, it actually is decreasing their recurrence rates by 80%. So those are big, exciting numbers for us. And so all of that working on local delivery strategies that target regional areas of recurrence, and things that either delivered before surgery or after surgery that decrease more distant recurrences are completely revolutionizing what I think of and do as a surgeon. I hope that's helpful.
Very. I mean, it's funny to hear you say that it's fun to be a surgeon right now, but I can understand that someone like you who can see that curing a patient or certainly improving the quality of life in a patient is very much in reach. You also look at the unique differences of lung cancer in women, and I wonder, how has our understanding of sex differences changed over the years?
So I think there's a lot of things that I think we're starting to drill down on. And it started out very much where it was the observation that women who had lung cancer, we fairly early, I would say, started to recognize that a number of them did not have a high smoking risk. And that was sad because they also, if they had a cough, no one thought to get a scan for them. No one thought to do the workup because they didn't seem to have the risk factors. So we often found them later, and they often had fairly diffuse disease. And what we noticed was, and Claudia can talk more about this, the actual appearance on the CT scans for a lot of these non-smokers who were women were very different in their appearance. They looked more inflammatory than a solid nodule. And we've gotten much better about understanding that those have to be watched, and we put them into, follow-up programs, much like we do other nodules, but they're handled differently in recognizing that a woman who's a non-smoker who has some kind of ground glass, we call it, appearing nodule, we have to really watch that. But women often will have multiple of those ground glass nodules, and it's almost like it's a very different disease and how we manage it and what we do. What's interesting is those particular types of ground glass opacities, or those types of lung cancers, have a much higher likelihood of having specific gene mutations, which also give us different options. So understanding that non-smokers, as you mentioned at the beginning, can be women, right? That more non-smoking women than non-smoking men can get lung cancer. Clearly, smokers have a higher overall rate. So I don't want to confuse people on that. But women tend to be younger in age. They tend to have better responses, as Nicole's already talked about, to different therapies. They tend to be overall healthier, so they have better survival and better outcomes, both from their normal health, but also because we think they respond better. And I think those types of things about having a different type of lung cancer, they tend to get adenocarcinomas more than some of the squamous cell, are a number of different things that are very different in women. And I think all those things together mean that we have to choose the therapy specific for the patients. But the biggest thing, if there was a message for us to get out other than we need to sort out why, because we do not understand, is for people to understand that just because you're not a smoker doesn't mean you can't have a lung cancer. And there's discussions that women who are waitresses or stewardesses, places where there used to be higher amounts of smoking, radon exposure, those things tend to be different. Sex-based exposures are also important to consider. And family history. Women are much more likely to have family history than men. Okay.
Well, again, thank you for all. We're so appreciative of all the work that all of you are doing. And Yolanda, thank you so much for what you're doing now in preventing, diagnosing, and treating cancer in women. As some of our panelists have already touched on, some changes and many changes have occurred, obviously, in the detection, diagnosis, and treatment of disease. And some areas in women's cancer still need to be improved. And the answers to the question of why in women, I think, is a pretty challenging one. So to support these ideas, we've launched a robust social media campaign, #3not30, to focus on what needs to be achieved in the next 3 years, not 30. We don't want to wait another 30 years for significant change to happen. And so I'd like to turn to each of you and ask what 3 not 30 might mean to you. Let's start, Claudia, with you.
Well, in 3 years, we could all work together, for example, and enroll into women into some of these exciting new approaches. That's one thing that we could do right away. And these kind of cohort studies are very useful for guiding new findings. The other thing is that never smoking women, we need to reach out to never smoking women to really let them know about their risks. And what Yolanda brought out is the non-solid or ground glass nodules, which we find in women. We find many of them have multiple of these, and you really need to tailor how you approach them, because the ones that maybe stay for a long time, some of them we've observed for 20 years, but then another one starts. So you have to, and you only have so much lung that you can treat or take out. So that's a study that we could start right away together, and say, how can we, what's the best approach? The other thing that we're doing is trying to make the screening more efficient and hopefully maybe less costly, so that the guidelines could be expanded. And we're doing that by because we have a large database that allows us to potentially to really use artificial intelligence techniques to see who can be automatically, that there's no change, who can be, we can find that there's no change in the CT scan, and those that need closer observation and what that observation should be. So that's a whole area that we're just starting in, and we're very excited about it. But there are all sorts of efficiencies that we could create in clinical trials for women as well.
Well, so much to do, so little time. Nicole, how would you like to make some changes in the next 3 years, not 30?
Yeah, I think sort of just acknowledging what's been done and jumping on the low-hanging fruit to sort of make immediate changes is really what we need. And so, the simple thing, if I use scalp cooling as an example, is lobbying the insurance companies to pay for it. Like, it should be covered. Someone posted in the chat about the mental health consequences of alopecia, and never mind the survival complications of choosing the less effective therapy. So that's a really straightforward thing where we can work together to get the insurance companies to actually cover it, and people to mandate that. I think when I think about, more globally, how do we really light the fire and expedite, especially the adverse effects research? It's encouraging, or really encouraging the drug companies who are running the clinical trials to include things like sex hormones in the panels that we check at baseline and on therapy. So there's some data that renal cell carcinoma, for example, has changes in FSH and LH, these very sex-specific hormones in men that doesn't happen in women. So if they didn't check it, they would never know it. So really encouraging the drug companies to just ask for those labs to be checked so we can follow them and figure out how we can intervene upon them. And similarly, having the drug companies capture the adverse effects specifically in women versus men, and making sure the granular data is really being captured allows us to have the data to work with. And that's something that can be done literally like in the next weeks to months rather than in 3 years. And lastly, I think getting the NIH and getting, funding agencies and foundations to really understand the difference and the need for funding is where, they put out requests for applications, light the fire. One of my colleagues this morning said, yeah, I saw that study on sex differences, but like, I can't change my patient's sex. And I was like, but if you understand the differences, then you can actually introduce sex-based interventions. And she froze in her seat and sat down. She's like, that's totally true. I hadn't thought of that. So by having the funding agencies actually put out the requests for applications, focusing on this, that brings it to light for the entire scientific population. It raises the awareness in the conversation, and it puts some funding out there to help expedite it. And all of those things can be done very, very quickly, I think.
Yeah, brilliant. I love that. Yolanda?
So I couldn't agree more with either of the panelists. I mean, it's spot on. I do think actually in kind of looking through a different lens, but probably the same message, is I think that artificial intelligence is going to be really important, particularly on lung cancer and the screening, because one of the difficulties is if you see a nodule right now, we have to follow with another scan to see if it changes. And our ability to start predicting, especially on non-smoking women or people with multiple nodules where the risk may be low for any given nodule, but how do you know? You're following all these different ones, and some require years to follow. If I could say to them, oh, that, you know, your chance of this ever developing into anything, one, it's a great quality of life measure for a patient to tell them that they're not going to get lung cancer, right? If I could tell them that, and they can move on and not worry about that. But if I can tell them it's a low risk, or how often do I have to scan them? Am I scanning them every 6 months, 1 year? You know, what do I have to scan them at is a major importance. And as a surgeon, none of us want to miss anything. And yet we don't want to scan people all the time either, right? That's not healthy. If it didn't change, I guess I didn't need to scan them, but I'd like to know what that frequency should be. And Claudia's done a great job in setting that up, but AI could really help us determine which ones matter and which ones don't. And kind of the same after we do surgery, we're caught in the same surveillance loop. How often do I do that? And so the other technology we haven't talked about is the idea of drawing a blood test and doing ctDNA. And we're now seeing that we can see that people have a tumor, we can detect it in their bloodstream, and then it goes away. And I think we're going to learn a lot on testing it. And when we start to see something, then do we scan people? And the ability to manage not just their cancer, but people's emotional fear of this coming back, which prevents a lot of people from getting the screening in the first place. Because we really haven't talked about that. There's two aspects to it. People who've smoked are afraid to everyone to tell them, I told you so. If you keep smoking, you're going to get this. So they'd rather not have to deal with the shame, so they don't get the care. And the people who are non-smokers, that then people ask them, did you smoke? Because that way I'm safe. And that makes them feel that somehow nobody cares about them. And I think all that stigma is the other area where public outcry can really help in letting people know there's a way to follow them. There's now a way to cure them, that finding it early makes a drastic difference, and that we're not going to blame people and say they're smokers and all they had to do was stop smoking is a judgment that doesn't help our care. And that's what I'd like to see over the next 3 years.
Wonderful.
And if I could just ask, for all of that, you really need a big database. So that's where we need to work together, pool our information and do cohort studies to drive the AI, all of those developments, which are very exciting and should result in a maybe automated reading, a first reading, which will make a big difference.
That's great.
Claudia, let's stay on that for a moment. I was privileged to be at a presentation recently to learn about a new program or platform that Microsoft is developing that is AI-based, obviously, but that can read and I'm sure, or I'm aware that AI has been used in radiology, at least for a very, very long time. But looking at where we are today with AI, how will that influence the work that you do?
Well, it's more that in order to develop robust AI techniques, you need to have a large database. And once you have the database and once you have the techniques, then AI will keep improving, will refine, will allow selection of cohort studies that you need to make to look at specific subgroups and so on. Everything, all of these things will work together to, but at the base is that you need to have a large database.
I mean, there are some studies that are looking that actually, there's a program, Civil, I know, that came through MIT and GH, where they're trying to look and say, they can look at a nodule on the first scan and at least get pretty accurate about will it become something or not become something. We need to do more and more studies. We need a larger database. All that Claudia says is true. But the goal would be that you could look at it, and if you had a large enough database and a large enough things, you could decide who you don't need to follow. That's where you want to get to.
Mhm. Nicole, is AI playing a role in the work that you're doing?
It's trying to. It certainly has developed a presence in pathologic reading of skin biopsy specimens, as well as in sort of total body photography. So we use a fair amount of AI in the Dana-Farber and Brigham cancer centers, where we use it for mole mapping. So we have a team of folks who take total body photography in patients who are high risk for melanoma, and then take really nice, zoomed in dermatoscopic photos, and the artificial intelligence actually comes back and tells us if it sees something changing or it sees a high risk lesion. So similar to what we're talking about here radiologically, except for us, it's right before our eyes, and we can just biopsy it very non-invasively. So it has sort of taken presence there. It's not widely used at all because it does require this big photographic platform and things like that. From a side effect standpoint, we're trying to leverage things like the EMR to sort of do a better job at more efficiently using it, like someone put in the Q&A, to really identify the risk factors. So who truly are the patients at risk for severe toxicities, and in whom can we intervene early, and what can we do to try to prevent those life-threatening or severe toxicities from developing in the first place? Because I think if you risk stratify, then who's going to best tolerate a therapy, and you can do things to stop it. So we have not made very much progress in the side effect world using AI, but I know people are really trying to leverage the EMR with all of its data points, the scans, the lab values, the other biomarkers, but still we come out saying like, well, our best biomarker for the risk of side effects in immunotherapy is, are you female? So that's still the most evident biomarker, despite all of this AI progress.
I mean, I think it's similar in non-smoking women. The idea is, what are these risk factors that we're missing, or why are people getting it, right? The most common risk factor is smoking. Well, that's great, but that doesn't work for the women who are not smokers. So what is it that we're missing that we need to do? And back to Claudia's point, that's a huge database looking at all these risk factors that we may not realize are risk factors. And that's what makes it hard.
And marrying the databases, I think, is really important. So we've done some work with like mapping, geographic mapping. So for some of our skin cancers, there's clearly, we call them the poison pockets in Massachusetts. I know where the rivers flow. And if you grew up there, I'm worried about the Superfund site I know you drank your water from. But putting the mapping data alongside the Environmental Protection Agency data, alongside our clinical databases, these are all things that could be done, but not by us, because we have a totally different expertise. We can simply identify the questions and the problems, and then someone else has to build these databases that talk to one another in an efficient way. And I think things would become much more clear.
We have a database, and we're looking for partners to work together. So hopefully we can get funding for that. We need a whole team, all of us working together.
Yep. Absolutely.
For sure. We agree with that. We can't be operating in tunnels and in channels. You need to be part of a larger ecosystem. There's been a lot written recently about women being gaslighted, especially when they're in a doctor's office. And I guess one of the questions I have for any one of you is, how can women advocate for themselves at the doctor's office when they're experiencing unexplained symptoms that are being dismissed or overlooked? That's not going to happen by any of you, but it happens.
Well, you should always ask questions, and then if you're not satisfied, go get another opinion. Now, the problem is that always costs money and time, but maybe there are you can go online and ask questions, and I don't know if we have an online system for women to easily address some of the questions. And we'd be happy, all four of us would be happy to answer some of those questions.
I mean, I think for women who think that if you have a cough and you have a cold, that's pretty normal. And if you have a pneumonia, it's hard for us to say much. If you have it makes sense. But if you don't have any of those symptoms and now you have a cough or something's going on, or if you have a family history, I think it's really important. Family history is really important for women particularly, especially if the family history was someone who was a non-smoker who had lung cancer, then I think those things should be brought to the doctor and you need to have a serious conversation about those. The trick, we don't have the data, is when do we start to scan or to screen people? Because that becomes hard, right? If you're a non-smoker, and I, as a clinician, will often try to take the family history into context and figure out how do we manage that we're going to follow that person or not follow that person. That's why I'm really hopeful for other ways of biomarkers and screening tests and things like that. But I think it's having that conversation with what you're worried about. And then I think it is, if you have symptoms, being persistent and talking about that not all women who have lung cancer are smokers. And unfortunately, not all the physicians know that. And so we need to get that point across.
I think it's I think I've certainly experienced it myself and I've witnessed it in family members. Gaslighting sort of runs alongside other stereotypes that are thrown at women, like hysteria and emotional and all that other things. Yeah. So I found the most effective way, in an encounter to sort of combat it is to just try to remain calm and factual with your concerns and to just call it out sometimes. Sometimes I will say, it sounds like you're really minimizing my symptoms. And I'm concerned that you're overlooking them because you believe you know something more about these symptoms than I do. Can you explain to me what you know more about in this context that's making you do this? And so being able to say, this is the percentage of women who are non-smokers who develop lung cancer, and here's why I'm concerned, and just stay calm and then call it out and then say, thank you. If you're not going to do anything further, I'm going to seek a second opinion and leave. And you have to be your own advocate, get some data to support it. But I think it's very easy to get really pissed off in that setting when you feel, even as a physician, that they're just not even listening to what you're saying. And so staying calm, being factual, and calling it out, I think, is the best way to try to get someone to pause and reflect on their own bias that's leading them to gaslight you. It doesn't work every time. We have a lot of work to do in that space as well, I think.
Oh, I think we have a lot of work to do in lots of areas. One of the data points that WHAM found was that there is inadequate monies being allocated to being able to answer some of these questions by NIH to study these different areas. So, for example, lung cancer, I believe, is 15% of NIH's budget is allocated to studying women and lung cancer, 12% in brain disease, 7% in autoimmune, when 80% of the people who have autoimmune disease are women, and 4% in heart disease, when it's the #1 killer of women. So we're perfectly aware that there is a need for more money for research. There's a need for more data. You've also all pointed that out. I have a question for each of you. Where do you feel that there are opportunities to partner with industry or business to move the field forward in taking sex and gender into account during drug and device development?
Well, we can kind of point out because we are all working with industry or with the pharmaceuticals, that we can point out that women are an important, or sex differences are important, and that we make sure we enroll and we require enough enrollment of women in any studies that we do. So we certainly advocate for that, and that's something we can all do.
Well, any other comments on that before I offer a couple?
I think it's particularly important in lung cancer because so many of these different mutations are differentially based on sex. So I think that pharmaceutical companies have kind of realized that that's really important, because had they not done that way back on the initial EGFR, it would have looked like these epidermal growth factor receptors, that initial data, it would have looked like it wasn't a very effective drug. The point was it was mediocre, but when they broke it out by sex, they realized it was wildly more successful in women than men. And so I think they learned that, at least in our space, that was a blockbuster drug versus a not, just because how they analyze the data. So I think they've got that message on at least.
I don't know if they've all gotten it though. I
No,
think
well, that's true.
it's getting that message out across space. And again, just
Yeah.
sort of encouraging or empowering everyone to sort of require the lens be considered, I think is really
agree.
important. Beyond the pharmaceutical companies though, how other businesses, only the other businesses know what their skill set is, right? So, clothing companies could develop chemotherapy related clothing that
Oh,
can
there's
help
a million ways. You're absolutely right.
each company, if they wear this, if they view it through their own lens, there are ways that virtually all businesses could invest in studying and improving women's health.
And
I
we
think.
could have a whole nother hour on how treatment decisions are made, because women take in their family, or they have children, or they have someone else, and that they may not be able to choose some best therapy, just like your cooling caps. That how do we make it so industry understands that we need to do X, Y, and Z so that it's equally available to everyone? Is the whole access and choice question are really important.
Well, let me share some data points, which I'll be happy to also send you as a slide. 50% of the workforce, 52% of the population, own 60% of the wealth in the country, make 85% of the spending decisions, and make 80% of the healthcare decisions, and the chief medical officers of their family.
Yep.
So women drive the economy, in case anyone doesn't understand that. That is the reality. That is the data.
Yeah.
I think if we look at it that way, perhaps we have a slightly different perspective. And if we realize that most of us, most men have a wife, a mother, a daughter, a sister, and they wouldn't have come into this world without a healthy woman. In any case, 3-not-30 is our call to action. And we believe very strongly that collectively, we do have the economic power to create change based on the data that I just gave you. And we recognize that women drive the economy. So it seems to me that we should be able, with that kind of data and with all of your insight and the work that you're doing, to move forward to make sure that women are not only in an equal and equitable position in terms of diagnosis and treatment, but in fact are a focus point given the data that I just gave you. In a few weeks, we'll be collaborating with our partners to focus on the innovation and ideas which will need to be created and shared and implemented to create change in 3-not-30. So WHAM's campaign is focused on what we need to achieve, as I said, for significant shifts to happen. And our goal for our roundtable, which will happen on June 13th, is for each of our partners to commit to a change within their company, institution, academia, business, wherever that partner might fall, creating greater equity, equality, and more research and investment, which they can implement then in their different entities within the next 3 years. I know that's ambitious, but I would rather be ambitious than wait another 30. I'm not sure I'll be here in another 30. Although who knows, with science advancing the way it has been, I hope that we're all having this dialogue, but on a different topic. So I certainly hope that you'll be joining us in creating your own ideas around 3-not-30. So collectively we can create sustainable, impactful momentum and advance the contributions we all can make to contributing to a healthier society. So for more information on WHAM, please visit whamnow.org. It's WHAMNOW.org, or follow us on social media. But most importantly, thank you to the three of you today. You're all incredible. The work that you're doing is amazing. I'm in awe. We all are, and we're greatly appreciative. We're here to support you to the extent that we all can. emotionally, financially, intellectually, and hope that we get to work with you more closely in the future. Thank you so much for joining us and for all the work that you do.